That's yours.
Good morning. So I'm very pleased to have the opportunity today to introduce Dr. Tom Huddle.
Yes.
Okay, thank you. Who is going to be our presenter today. Dr. Huddle is a professor in the Department of Medicine, Division of General and Internal Medicine. He has had a career-long interest in medical professionalism. He got his undergraduate medical and doctorate degrees in the University of Illinois in Champaign-Urbana. His PhD is in the history of medicine, and he has ever since had a strong interest in medical ethics. He's written pretty broadly on all kinds of things, from the role of physicians and physician-assisted suicide. Actually, I haven't read his paper on that, so I don't know exactly where he stands, but to all kinds of issues around decision-making. And he has a particular interest in the history of research in medicine and the kinds of issues that have come up that have led to the current systems we have for protection of patients who are subjects in medical research. So I'm not going to take any of his time, so I'll just warn you that he's very dependent on an interactive session. So for those who are off-site, I'll be monitoring the chat box, but feel free to leap in with a question just through your microphones if that works. If I hear too much background noise, I'll have to mute everybody as a group and just look for chat box content. So if you can mute yourselves when you're not speaking, that would be very helpful, but don't forget to unmute yourself when you're ready to ask a question. And then we'll take a break in the middle. So last week, you all heard that we'll be starting the sign up for the local people to participate in the visits to the IRB. Jean is still trying to work out what the start date for that is going to be. She hopes she'll have that worked out by our mid-session break today. So during the short break, if you can take a look out in the entranceway to the building here, Jean will probably have a sign-up sheet for you to work with, and if not, then hopefully by the end of the day today, and worst case scenario next week. Okay, so Tom, thank you.
Thank you, David. Hello, everybody. Good to see you all. I gather from David, at least on previous occasions, that you all are a mixture of various backgrounds, including both clinical and more bench basic science. You're all interested in research that might potentially involve human subjects. So this session is an attempt to sort of introduce you to and hopefully generate some discussion about the current regime, if you will, of research oversight to which all researchers getting federal money at least are subject. My own background, I mean, as David mentioned, I'm more of a clinician. I mean, I'm not a researcher in the sense of the sort of funded research with human subjects that you all are interested in. I do more conceptual writing, but I did spend 8 years on the IRB. I certainly developed a sensitivity to the sorts of concerns that researchers have about the IRB and about the IRB process, which many find to be rather onerous and burdensome. So I do bring that to the table, even if I don't bring a background in doing human subjects research myself. I sort of presented a brief AV presentation. Hopefully many of you had a chance to look at it, and basically what it did was go through a little bit of the history of the development of our current research regime, the common rule that was basically laid down in 1981, so we've now had this process for the last 36, 37 years. A description of what resulted from that, institutional review boards, how they're made up, the basics of how they work, the human subjects protocol, and then what the IRB process is actually like from the perspective of somebody who participates in it. And then a little bit about criticisms of the system. Many researchers would argue that it's way too onerous. Why should you have to do this? We're not the Nazi doctors. We're actually well-intentioned people. We're ethical. Why subject us to this bureaucratic morass, rather than just let us do our thing and, we're going to be ethical. On the other hand, a lot of people would argue, well, it's not rigorous enough, particularly the people who have been involved in research mishaps. Many of them would suggest, the process is not really catching bad stuff that it ought to be catching. It should be more rigorous than it is. If anything, it should be more onerous than it is. And there's this back and forth, which certainly continues in discussion today. We can consider, what might be the validity of either of those points of view. So what I want to do today is unpack a little bit more of the historical context, talk a little bit about the kinds of criticism in a little more depth that were brought to the formulation of the common rule in the 60s and 1970s. Ask these questions: is the present regime too onerous? Is it too loose? How could it be improved? What do we really think about that? And then maybe in the second hour, if we get a chance, we'll talk about a particular research mishap, the Jesse Gelsinger case, the University of Pennsylvania back in the late 90s. At least at that time, it was very much in public discussion, and maybe shed some interesting light on the broader questions. Now, so what led to the development of the common rule? The immediate stimulus were a couple of things. Probably most notably the revelations of the Tuskegee experiment in 1972. Big article in the New York Times revealed that black men in the South with syphilis had been basically untreated for it under the auspices of a public health study from the 1930s up to very near 1972. In spite of the existence of good therapy for syphilis by 1972 for quite a long time, since the development of antibiotics in the 50s. That was sort of a mind-blowing kind of revelation, which sort of got everybody very, very sensitized to abuses that perhaps the medical profession was perpetrating on research subjects. And another article, or another revelation that perhaps is not quite as notorious as the Tuskegee revelation, was the publication by Henry Beecher, an anesthesiologist at Harvard in 1966, of an article in the New England Journal of Medicine that basically beat out a series of research projects which he argued were unethical, that should not have been conducted in the way that they were, and that amounted to an indictment of the research establishment, the research enterprise as it was being conducted in the U.S. at that time. Experiments like the Willowbrook Hospital hepatitis experiment, in which young children were infected with hepatitis A, in an attempt to see what were the effects of gamma globulin. If you gave them gamma globulin, and then if you gave other children, did not give them gamma globulin, would the infections be milder or would they be prevented? But basically, children who don't have hepatitis, you're infecting them with it deliberately in the course of an experiment. Jewish Chronic Disease Hospital, elderly Jewish residents of the Chronic Disease Hospital had cancer cells injected under their skin in an attempt to study the immunology of the response to cancer. And they don't know about it. They don't know what's being done to them. So, that's two examples. There were a bunch of other studies that Beecher talked about. So that, the Tuskegee experiment, and then in the background, of course, there's the memories of World War II, the memories of what the Nazi doctors did, the kinds of sort of quote-unquote research that they conducted, and really public revulsion against all of this, and the feeling that, this has to change. We need to do something. Things need to be different. How can we police the research enterprise so that stuff like this doesn't happen? That's sort of what's in everybody's mind as people develop the common rule, think about how this needs to work, and of course, you know what they came up with. They came up with the regimen of institutional review boards and the process that, you know, now many of you perhaps are familiar with. Other things that were cited by Beecher, so a study of placebo versus penicillin for strep throat, even though it's pretty well known that penicillin works for preventing the complications of strep throat. Is it really ethical to give somebody a placebo? I mean, if that's the case. Chloramphenicol versus usual care for typhoid fever, even though it's known that chloramphenicol dramatically reduces the mortality from typhoid fever. The liver toxicity study of a new antibiotic in children. The antibiotic's known to cause toxicity, and children are used who had no indication or condition requiring antibiotic therapy. So, you know, why harm, you know, healthy children in such a study? And then people that are undergoing bronchoscopy for various reasons, unbeknownst to them, without consent, without even knowledge that it's being done, are having their heart cannulated in an attempt to see whether that can be done and whether it's practical. Once again, without consent. So all of this seems pretty egregious, pretty outrageous. The medical enterprise appears to really need some help, some work. But many of the mandarins of medical research during this period, as the common rule began to develop and as they began to see what was going to happen, protested mightily, protested vigorously, protested loudly. You know, this is the wrong direction to go. We do not need a research ethics bureaucracy. Yes, some bad things were done. Yes, some things happened that shouldn't have happened, but we are not those people. We are well-intentioned experts. We who now are doing this research know, we're the best judges of how ethical research ought to be designed. And any bureaucracy is simply going to impede we being able to do what we need to do to develop new knowledge to make lives better. What's really important is the virtue of the researcher, not somebody looking over the researcher's shoulder. Any attempt to look over everybody's shoulder it can only go so far and is clearly not going to prevent bad things from happening if a bad person is really doing the research, and we are not bad people. We now in 1970 and 1980, we're good people. This is an overreaction. The public climate in which all this is being discussed has become hysterical. It's become fanatical. There's sort of an atmosphere of McCarthyism. And it's wrong that this completely onerous process is being imposed upon us in this climate of fear and overreaction. And then Walsh McDermott actually goes a step further. Society's interest in knowledge sometimes transcends the individual interest. Maybe some research subjects actually do end up making a sacrifice, and maybe they don't benefit, but maybe that needs to happen. Maybe society interest outweighs individual interest in some situations. So I mean, how do you react to this kind of argument? I mean, how do we react to it now? In the early 1970s, in the late 1970s, it was, a lot of people were saying things like this. Was there any, validity to what these guys were saying?
Yeah, but it was contextual. I mean, at that time, it was a very paternalistic, hierarchical society, right? So, it's under, no, it's not correct. But at the time, not just in research, I think in many avenues, that attitude was expressed.
So society was very different.
It was very different.
Institutions like all sorts of institutions, but medicine in particular was on a pedestal. Physicians were highly respected. Medical researchers in particular were deeply, had a position of authority in society, and their voice carried weight that it doesn't carry today in anything like the way that it did at that time. And I think, you mentioned context, and I think context is very important. I mean, if we think about the bigger picture in the 1960s and 70s, we're seeing a kind of revolt or reaction to authority and its abuses, not only in the field of medicine, but in all sorts of other areas, all sorts of other societal issues or sort of working out that way. I mean, the protest against the Vietnam War, for instance, and in the clinical realm, the rights of patients. You doctors are sort of telling everybody what to do, and that's not right. And why? The issue of consent and the issue of autonomy is important, not merely in the research realm, but in the clinical realm as well. The same kind of reaction against medical power, medical paternalism, and medical authority overstepping its bounds is happening in the clinical realm just as much as it's happening in the research realm. And other institutions like the military, the government, are under the same kind of protest and resistance that medicine is. So one way to look at this is all sort of part of a pattern of things that are happening at the same time. And I think to us now, I mean, much of what people like McDermott and Inglefinger were saying seems fairly outlandish. Who are you to say that the individual needs to give way to the collective? And I, Walsh McDermott, will determine exactly how that's going to happen. I mean, that strikes us now as if, he had a bit of a God complex. And maybe many in the medical profession had a bit of a God complex during these years. Is there any validity to anything they had to say?
On your last slide, you made a point that they said that there should be a focus on training ethical professionals. And I think maybe that in combination with oversight is a good point. They need to be done simultaneously, not separate.
So maybe there was something to be said about the spirit of the law versus the letter of the law. I mean, a bureaucracy, maybe we do need to have some sort of oversight, but if it's mostly bureaucratic and if it's mostly sort of, cross your I's and dot your T's, maybe you are missing something, or you could be missing something if that's the main thrust of what you do. Maybe there is some validity to making that point. Any other thoughts?
I mean, I feel like this argument that they're making is sort of ironic because that experiment with the prisoners and guards, which itself is an unethical experiment, proves that anyone who thinks that, that they're good people and would never do anything to hurt other people, like anyone could actually, do harm without, needing to. So I think this argument is...
So the protest...
Could you repeat this?
So if I get you correctly, the thought that we're good people and that's going to be enough to sort of underwrite our good behavior, and you don't need to worry about us, that rings hollow because we know that good people sometimes do bad things. So no, I mean, just being a good person, I mean, that that isn't good enough. You know, we need more than that, and we may need some oversight. We may need some over-the-shoulder observation, even for good people. And I think that's a completely valid point. So nevertheless, I mean, so those arguments obviously did not prevail. We got the regime that we got. If you do human subjects research, I mean, you have to, fill out that 16-page human subjects protocol, and you have to respond to the IRB, and, they will sort of go over your consent form with a fine-tooth comb, and they will nitpick you, and a lot of researchers still argue that, maybe we need something, but is this really the right process? Is this really doing what it needs to do? And, some of the more pointed critics also ask the question, well, so we have this huge, expensive process. What do we gain from it? Is there any way of measuring what we gain from it? What exactly are the benefits here? Is research more ethical because we have IRBs? And, the implied answer is hard to say and maybe not. At this point, I mean, do you all feel like the common rule and IRBs and this whole process, this is good?
I would say that, you have a group of people. So you have a group of people that are kind of outside the researcher's realm of what they're doing, and I think that kind of allows, some form of, I guess, removes bias in a sense, which, the Gelsinger case, the researcher had, interest in, in the company and stock or whatever it was. And I think that's important because, the IRB's bringing in someone from the community. They're bringing in other researchers who have perspective with what's being, reviewed. And I think that kind of allows more open-mindedness, and while it might be a little bit more rigorous and maybe more opinions for certain things, I think it's helpful because, if you're kind of in your bubble, you're not really always going to kind of see those perspectives that you might gain from an outside view.
So the person involved, of course, has special knowledge and ability, perhaps, in regard to what they're doing, but that person might also have blind spots. And having people that, perhaps don't have the same kind of expertise might actually be something useful and beneficial. And I think that's that's the way that, many people might respond to, what they were saying. I mean, yes, you have a point. In some sense, the investigator is sort of the best qualified person, probably knows more about what he or she is doing than anybody else. But on the other hand, that person may also, be misled or have things that they're not seeing or not feeling as they should, and having an uninvolved person that might actually be an advantage. Very valid point, and I think a good response to the kind of argument that Engelfinger and McDermott were making.
To me, I think the IRB review can really help find the blind spot that the researchers were not able to think of, or hidden conflict of interest. But from my experience, I think it gives you an opportunity to think twice. When you have a research idea and you are kind of eager, you're motivated to prove that or show something. And by the fact that you just have to let someone else review your protocol, like the IRB, that makes you think once more about, is this justified? Am I causing any risk to my patients? Can I change my protocol to make it safer for our participants? I think it just gives you an opportunity to think again. So that's, I think, a benefit of IRB.
So oversight, having to pause, having to go through this process, yes, it's a lot of work. Maybe it slows you down, but it does make you think twice.
Make it a better protocol for everyone.
From an ethical standpoint.
Yes.
Yeah.
When Carrie Oliver was here last week, she made the point that in her, I guess, 15 years of being on the IRB, she had only seen 2 cases where the study was totally rejected. Everything else had modifications, of course, modification. So the question is the research more ethical via IRBs? I think that's something that someone like me who doesn't have a whole lot of experience in the field can't judge because we don't know what the proposal was. We know what the outcome was, and usually the outcome is ethical more or less. So to say is the research more or less ethical, you would have to sort of know a lot of details. As you were saying, it can be difficult to judge, but the public can't judge it because they don't have the information. Even a lot of the researcher cannot judge it because they don't have the information. They don't know what was proposed versus what the end product was.
So it's a hard question to answer, whether there are benefits and exactly what they are from the IRB regime. And I think you would make the case that it's even harder than you suggest because, how would you really know? You would have to do a comparison. I mean, you would have to look at, a ream of studies that were produced, without an IRB regime and then compare those to a ream of studies, that were produced under IRB auspices. And of course, we can't do that because it's a counterfactual. And those who argue that things are too onerous and rigorous would sort of say this, the kind of thing that I think partly you might have said was that a lot of people might say, well, if you look at what actually comes into the IRB and, what comes out of the IRB, there's not a lot of difference. Very, very few studies are altered in any substantial way. And isn't that evidence that, IRBs really aren't accomplishing very much? What might you say in response to that? Yeah.
I mean, the whole motivation to create the IRB were these horribly egregious cases. So I don't think the point is to affect all the research projects. It's really to catch these, and prevent, really egregious cases from happening again, which are very rare. So, 99.9% of the cases aren't going to benefit from the IRB, and it's going to be just more work for them. But if we can prevent some of these historical cases from happening again, that's the point.
So one thing you might say is, well, yes, we can't do a randomized controlled trial, but we can look at how things were before the IRB, and then we can look at how things have been since then, and we can say, compared to 1966 Henry Beecher revelations, things seem better now, and isn't it very plausible to attribute that to the regimen of IRBs? So that most likely IRBs have done a lot of good. And yes, the fact that lots of studies are submitted to the IRB and they come out and they don't look very different. Well, what does that mean? What that means is that the very existence of the regime is in the mind of the researcher when they're developing their study, and so of course they're going to develop it in a more ethical way because they know that they're going to be scrutinized. So the existence of the IRB regime most likely is the reason that studies look so good going into the IRB. So, nobody can answer the question definitively as to exactly what the benefits have been, but a lot of us would make the argument that it's very plausible to suppose that IRBs have done some good, probably a lot of good. Now, there might be a little bit of a counter-argument when we start looking at research mishaps and look at the things that, perhaps have slipped through the net. That might be a further part of this discussion. But certainly, the kind of question that, a lot of people are asking now is, even if we grant that an IRB regime is a good thing, probably IRBs have done a lot of good, can we tweak it? Can we make it less onerous and still effective? There are ways that that the IRB regime can continue to produce more ethical research and ward off unethical research, but be less of a burden to the researcher. So I think in asking that question, I think we need to look at what's been happening recently. What sorts of bad things have happened under the regime of IRBs Could they have been prevented? If so, how could they have been prevented? If we're seriously interested in how can we do things differently. So what are some things that have happened recently? And I picked these. These are among the cases that in the last 15 to 20 years have sort of been notorious. And I think I can't say that I've sort of systematically combed through all the research mishaps that have happened, but these are some of the big ones, and I think it's reasonable to sort of look at some of these and say, well, what does this imply for the IRB regime? So what are these? The UK ECMO trial, extracorporeal membrane oxygenation for infants with pulmonary hypertension. This technology is developed in the United States, and it works. Pediatricians are convinced that it works. Infants with this condition who get ECMO, they do better. And then in the 90s, somebody decides in Britain, well, there's never been a trial, so let's do a trial. Are we really sure that it works? We really, we need to do science. And they did a trial, and they randomized infants with the condition to ECMO or non-ECMO, and sure enough, ECMO looked a lot better, and the infants that didn't get ECMO, a lot of them didn't do very well. And a lot of pediatricians in the United States said, how could you possibly have done that? It was completely unethical. We knew this worked. You needlessly subjected, infants whom you could have helped to not getting help, and they didn't do well. A UAB study. Have any of you heard of the BioCris study? Led to the downfall of the chairman of dermatology back in the early mid-90s. Basically, a trial of a topical treatment for cutaneous T-cell lymphoma, a rather rare cutaneous malignancy. Basically, data was falsified to make the treatment look better than it actually was. Not by the PI himself, but by people who were working for him, who had an interest in the success of the agent with the company. So it was data fabrication / fraud. It was exposed, and it was a big deal. The Gelsinger case we're going to talk about more. Jesse Gelsinger dies in the course of a phase 1 trial of gene therapy. Hexamethonium study. This is sort of a basic science study. It involved healthy volunteers, and a healthy volunteer was given hexamethonium, which is a ganglion blocker, and they were studying the protective effect of deep breathing on bronchodilation. And you give somebody hexamethonium, that potentially interferes with that protective response. Hexamethonium was felt to be safe, and it was an appropriate agent, so the investigators thought to study this issue. But they didn't do a complete review of the literature. They only did what Medline will do, which is back to the 1960s, and it turns out in the 40s and 50s, hexamethonium had been used as a blood pressure agent and had caused serious pulmonary pathology back in the 40s and 50s, similar to the pulmonary pathology which affected the healthy volunteer in this more recent study and led to her death. So the criticism was the investigator, didn't do enough background, and had they realized that this agent actually could have caused this syndrome, which actually developed in the volunteer, she was never told about that possibility. Maybe A, she would have been told. B, maybe they would have completely, not even done the study had they really known about this. TGN 1412, a monoclonal antibody intended for various malignancies, phase 1 trial, just to attempt to see that it's safe. In the phase 1 trial, several people at some dose, and whatever dose they got to, basically got sick and died. No real accusation that anything was done wrong, but a very bad outcome. The support study, another more recently notorious study based at UAB. An attempt to understand the trade-off between the use of oxygen in prenatal or preterm infants in terms of, saving them from multi-organ failure on the one hand, but causing blindness on the other hand. And in the aftermath, accusations were that the trial should have been designed differently and that the consent process did not give patients enough information. Basically, preterm infants were put in either a high oxygen group or low oxygen group. Previously, this had all been just clinical judgment and nobody really knew, what was going to be the best thing. So the thought was you systematically give everybody high oxygen and everybody low oxygen, and then you can figure it out. Unsurprisingly, infants who in the high oxygen group, some of them probably went blind unnecessarily. And that was the concern. Should the trial have been done differently? Should there have been an arm, a usual care arm, in which pediatricians made individualized decisions so that could have been compared with the high oxygen arm and the low oxygen arm? And should mothers have been told more clearly that, there's a real risk that your baby could go blind unnecessarily in this trial? And the thought was that risk wasn't sufficiently highlighted. The CAFE trial, trial of antipsychotics and trials of psychiatric drugs are often a little bit different in that the subjects of them who are mentally compromised sometimes don't have the prerogative themselves to make a decision to leave the trial. And this was a case where a subject of the trial had a mother who was really attentively watching him. He wanted to stop the drug. She wanted him off the drug. She went to the investigators in the trial. They would not stop the drug, and he committed suicide. And I think most who have looked at this trial, regard those people who kept this kid on this drug would say they did the wrong thing. They should have stopped it. Finally, an investigation of genomic chemotherapy sensitivity predictors at Duke. And this was another case of data fabrication. Somebody wanted the study to work, so they fabricated data to make it look good, and that was discovered.
I bring up a point that one of the off-site people has typed in. So I guess this kind of issue doesn't necessarily only come up in the biomedical research arena. So one of our colleagues says that recently there was a study on the news that suggested unethical practice by Volkswagen, who was examining the effects of diesel exposure to humans and monkey subjects without apparently standard IRB kind of review. So that kind of thing can happen as well. And the same person, I was busy getting new batteries for the microphone, sorry I was out, wanted to make the point that requiring more people from the community to be on an IRB, you could make an argument that would improve its ability to help assure good outcomes from the kind of reviews they do. And that only requiring one community member is maybe a little bit underpowering the group.
So how many representatives of the community should be on the IRB? I mean, I think that's certainly a discussable question. And, a lot of people have made much of the fact that, it's only human subjects research that's funded by the federal government that is, formally under the requirement of this entire process. And other human subjects research can take place if it's not funded by the federal government. It doesn't necessarily need to go through the IRB process. And that's one of the things that has been, as people have been talking about, and eventually, which we may get to, they did revise the common rule in the last couple of years. They actually, a revision was completed in January 2017, and it just took effect. That was one of the issues that people were talking about, was extending the reach of the IRB regime so that all human subjects research, not just that, federally funded, would fall under it.
Question.
Yeah.
If they're going to expand it to, like, I guess, private industry, who is paying for the IRB then? If, you know, if we're going to have an influx of more oversight, will the private industry also help fund that as well?
That would be the thought.
Okay.
And that, you know, to the extent that industry-funded trials are scrutinized by IRBs now, I mean, that's how it works. They do contribute to the...
Yeah, they're actually, I don't actually know what the cost is, but there are some non-university-based IRBs that people use when their institution doesn't have their own IRB. So there's something called the Western IRB that a lot of people use, and they charge several $1,000s to do a review. I don't know exactly how much it is, but it's a significant cost, but it reflects the amount of time people take to do the review.
And that's another topic of controversy. So, you know, so you have a for-profit IRB. I mean, what does that mean? You know.
I'm not sure it's formally for-profit.
But effectively, I mean, that's kind of how it works.
I have a question, a little bit more general about the fact that, you know, we live in the United States, and the moral code here in the United States kind of, you know, spreads all throughout the, you know, Western European developed countries. But what about some of the political drives that are driving to do some types of research to only claim that, you know, this country is far ahead in one research over the other? And we have plenty of those examples coming from the development of Russia in the Cold War, who's going to go to space first, et cetera, et cetera. Or now, for example, CRISPR-Cas testing in kids and infants in Korea, et cetera, et cetera. So
the thought is there's a nationalist impetus?
Yes, and for example, like how would, you know, as global citizens, we would assess those problems, and then, for example, how would we even assess here in our country some of the studies that are done by the Department of Defense when a lot of the information is much more closed off due to some of the political reasons?
So, boy, several interesting issues there. I'm not sure what to say about the issue of nationalism. I mean, my sort of impulsive response is to say, well, you know, if you know, the U.S. is very successful at doing research, is that a bad thing? Maybe the reasons for it could be wrong. I mean, if a lot of the impetus for doing study X is simply to sort of say, you know, we're the best and beat our chest, I mean, that seems not so good. Is that really happening?
Especially in the CRISPR-Cas system right now. The CRISPR-Cas is moving very tremendously, and I think, you know, some of the more Eastern countries are doing research involving human subjects when it is not allowed yet here in the U.S. using the CRISPR-Cas due to the fact that we really do not know yet how it works, and it has not been studied to the point that it has to be before we even move to human subjects. And also,
so maybe research is being done in a dangerous way. But the thought is let's be competitive and let's get there first.
Yep. And for example, the same thing with the stem cell research. A lot of Chinese companies have moved that to allow for extensive research in the universities throughout China and throughout Korea, just for the fact that they would be competitive and they would say, you know, this type of therapy has been done here in these countries, but not in the U.S., where we are much more prohibitive of what studies are done on the much more cutting edge, understudied treatments right now.
Well, clearly there's a big danger of you know, and if we get to the Gelsinger case, we'll talk more about that. You know, the desire to be first, the desire to, you know, get the patent in, the desire to, you know, be able to, you know, make big money. Those are very important motivations for researchers. You know, can we eliminate them? Arguably not. But do they lead to the cutting of corners? Probably they do. And do we need to guard against that to whatever extent we can? Absolutely. And, you know, how best to do that, I guess, is another discussion. I'm not sure I have an answer to what's happening in other countries. Let's go ahead and take a break and come back in a few minutes and take it further.
Right.
It's always fun.
Yeah. So I heard about an example where there was a study being done with NIH support, but the study was being done in, I believe, Africa or India. And it included something about testing related to human papillomavirus vaccination. And there was a person who actually was a high schooler who told me about this, that he felt that the failure to include a standard pap smear arm in the study was unethical because, in fact, from his perspective, using pap smears effectively has a bigger impact on survival from sort of cancer vaccines, which have a 20-year time span before they begin.
That sounds like a potentially very valid point.
So I don't know whether, I didn't know enough to know whether to ask him about whether the IRB that reviewed that kind of study was Washington D.C. based IRB from this NIH group, or was there no IRB because it was being done in another country? I'm sure there had to be some IRB, but do you know what the standards are for research that's carried out by U.S. investigators on overseas populations? I assume it's the same, that it would be a very good evaluation.
It's a huge topic, and a lot of people argue that we need to be even more careful when that's happening.
Sure. Well, we're just taking our break, so we'll.
Oh my God. This guy's bleeding down. That was a question I know, like, how do you decide what is vacation? I know, just really.
So, comment about the study where they used to candidate the heart for the bronchoscopy, and you said that people didn't know the consent. If they did, would that be ethical? If they told people the consent, would that make the whole procedure ethical?
That is a good question. I think the short answer is that just because you consent to something doesn't necessarily make it ethical.
Yes, and this necessarily means that the patient actually understands what you're talking about. Sometimes people just, like, they don't know that much about science, and they will just think that, okay, I understand, and they'll just consent. But it's basically the IRB who's supposed to decide whether it's a, then to at least get to the stage where you're talking to people and you're actually getting consent. So,
I mean, I think, to make a decision like that, you need to have some sense of how this, what are the risks of cannulating the heart during a bronchoscopy? What's the complication rate of that? How many bad things are happening? And if any substantial, significant number of bad things at all are happening, probably it's not ethical.
And then you will never be able to do that research, is that right?
Well, I mean, maybe you develop it in animals, you get it to a point where it's really safe in animals. Could you justify doing a pilot study in humans? Maybe you could. If they really, if people are really willing to take the risk, and maybe the benefits you're going to get from being able to do this, if those benefits are going to be very great. I mean, but those are the kinds of arguments you'd have to have.
I was talking in an undergrad class, and one of the students asked me that human anatomy, when they started studying it back in the history sometime, so they used to dig up the corpses without anybody knowing it, and then just cut them up and see where the heart is and how things are located and everything. And if they hadn't done that, that was super unethical. But if they hadn't done that, we never have found anything about anatomy. So how do you deal with that kind of?
Well, you're right. I mean, you're right. There are different views of the human body at different periods of time.
Embryology, for example, there are different stages of the development of fetus. Some of the cases were when the baby was no longer viable, they just took it and studied it. But some of the cases were like prisoners, women prisoners who were we went through those experiments and they just used it to understand embryology. And now we benefit so much from it. So what if IRB was back then and they would not have allowed that? So,
well, a lot of people would argue that no, if for instance, if useful knowledge came from Nazi experiments, that knowledge should be suppressed. We shouldn't make use of it. It's too tainted. And that kind of argument is out there.
Like, there's so many medicines based on that knowledge. Like, we're treating so many things, and nobody does something knowing that it's wrong. So everybody has a justification of doing everything wrong. Like Nazi experiments, the people who were actually doing it had a justification and a rationale.
In their own heads, they did.
Yes.
Well, you're just pointing out how difficult this whole area can
And the
be.
decision is so difficult. Like,
Yeah.
if IRB was back then probably we don't know that much about all these things. So that's really.
And that would have been better. It would have been better to do things right than to do things wrong.
Yeah. Yes.
Some would say.
Yes.
Many would say.
Yes, definitely.
Every choice is rewarded.
Exactly. And they would have found, like, human mind is so marvelous. They would have found another way and alternative to those things rather than doing it out. Like, they would have figured out something like X-rays or whatever.
Yeah,
They were
right,
always
right.
valuable options for
Right.
these things. So.
Development would have happened some other way. Absolutely.
While we're reactivating here, I just want to bring you up to date on a few other chat items that came through. So one of our colleagues made the point that we should recognize that just because somebody is diagnosed with a psychotic disorder, that doesn't mean that they're not necessarily competent still to participate in research setting, and that so there's a lot of issues around what undercuts a person's ability to speak for themselves.
Absolutely.
And yeah, it's interesting. So related to that, I have a son with Down syndrome who's 27 now, and he was invited to be a participant in a research project. And from my perspective, he votes. He makes better judgment than a lot of people I know who vote. He does a lot of, he lives his own life. So just having that diagnosis, from my perspective, didn't undercut his ability to make a sound decision. But my sense was there needed to be some extra protections to be sure that he got information in a way that he could understand easily, and so that kind of thing was done. And the system has the potential to be quite flexible, but it needs to be thoughtful, obviously. Okay.
Want to go ahead?
Yeah, let's go ahead.
Okay. So before turning to the Gelsinger case, let's just play this out a little bit. For those of you who just came in, we were talking about the fact that we have this regime of research oversight. We talked a little bit about what it was, criticisms of it, could it be done better? And one avenue of thinking about maybe how could it be done better is to look at recent research mishaps and sort of ask ourselves, could the IRB have picked them up or prevented them? A, that question, then B, maybe are these really different from what was happening back in the 60s and 70s? Have we come a long way? Have we not come a long way? And what does that imply about the IRB regime? So we went through some of the more recent things that arguably have been mishaps. And, what do we conclude from looking at those mishaps? One kind of argument might be that, well, look, things are really different now. Yes, there still are research mishaps. We can't eliminate them completely, and maybe that makes sense. But, what kinds of mishaps are there? Well, there's, in the case of research misconduct, well, there's bad apples. And, is the IRB regime going to prevent that? Arguably not. You know, if somebody's going to fabricate data, it's very unlikely that the IRB is going to be able to keep that from happening. You know, then you have research that is ethically designed, but people cut corners in the conduct of the research. You know, can the IRB prevent that? You know, maybe only if the IRB starts doing things differently, if it starts doing real-time research monitoring and, you know, occasionally visits your lab or visits, you know, your clinical center where you're conducting a trial and actually looks at what you're doing. I mean, that would be even more onerous, more difficult than the current process. And then, you know, good science that happens not to work out well, the monoclonal antibody trial. I mean, there are always going to be occasional bad outcomes. Isn't that the price of doing research? You know, do we not simply have to kind of budget for that? And if, you know, if all that is the case, you know, the research oversight skeptic might say, you know, are we really doing all that much good? You know, these things are still happening. The things that were happening in the 60s are not happening. And they're not going to happen because we have a different climate, ethical climate now than we did then. And, you know, the IRB regime is sort of superfluous to that. So maybe we could be less, either be less onerous or, you know, really get in the researcher's face and look at what they're doing in real time. You know, maybe it has to be one or the other, and it shouldn't be that. So if you're a research oversight advocate, how might you respond to that kind of skepticism?
I have one comment about one of the, I think, unintended consequences of IRB oversight is a lot of minority populations get excluded now from research. There's like a skew of research away from those populations because of the safeguards. And I think that's been an unintended consequence. So, and maybe it's because there's not faith that the IRB is truly protecting minority participants, and so they decline to participate, or researchers don't want to do the extra steps to include minority participants, and so they design their study to exclude participants. But that's a big problem for, you know, a lot of new therapies coming to market. When you look at the participants of minority groups, they've been excluded in the studies, and so we don't actually have the data available.
So I guess you could make an argument that the way that the IRB process has worked out, that has been one of the consequences. A lot of us would probably want to say that, you know, with the concerns that led to the development of the common rule in the first place, there were very legitimate concerns about vulnerable populations and their place in research, and the historical example of minority participants in research perhaps being more subjected to abuse than others, and therefore needing extra protections. And maybe in the long run, that completely understandable desire to protect vulnerable populations has also led to some unintended consequences, that minority participants don't get studied as much as the rest of us do, and therefore maybe don't benefit as much from research. I mean, I think that's a discussion that is very much going on, and, you know, everybody's thinking about ways to fix that problem, you know, without throwing out the baby with the bathwater, with still protecting vulnerable populations in the way that we need to do. But you're right. I mean, that's a difficult issue. I think there might be more to be said to the kind of skeptical argument that you might be able to make from looking at recent research mishaps. And probably, you know, one of the most important things that could be said is that if you actually look at some of these problems and compare them to the 60s, some of them are not all that different. You know, when do you need to do a trial? Is it ethical to do a trial of penicillin to prevent the complications of strep throat if the trial has never been done, even though we think it works? We think a treatment works. Do we really know a treatment works if we haven't done a trial? Is that really a bad question to ask? That's basically the question that was the UK ECMO trial. It seemed very analogous to deciding about the ethics of a study of penicillin for strep throat. And an IRB can wrestle with that. Surely that's the kind of question an IRB can usefully wrestle with. And isn't that, 1990s, 1960s, no difference at all. Same thing for chloramphenicol and typhoid. Issues of consent, consent in the support trial. Surely that's exactly the kind of an issue that an IRB could usefully wrestle with and perhaps help investigators with. So what, the counter-argument might be, sure, in some respects, the mishaps of the present are very different from the mishaps of the past, but they are not without some similarities. And what those similarities demonstrate is that there is a role for IRBs, and probably a very useful role, even though IRBs can't do everything. Perhaps IRBs are going to have a tough time with research misconduct.
So one more point in that previously used drugs that everyone believes it works, but there's been never a trial before. It's not only a problem with the clinician knowing this is really working or not. Also nowadays, the insurance companies would often deny the medication because the FDA did not approve it without clinical trial data. And that actually affects our patients. For example, in myasthenia gravis, prednisone has been used 50 plus years, and we know that it works, but it's never been tried in the trial, and it's never been approved by FDA. Right. So after 50 years of treating myasthenia gravis, only last year, one drug has been approved, that's eculizumab, after the clinical trial. No other medication has FDA approval. And we're dealing with the insurance company all the time. So they deny the medicine because there's no FDA approval with the clinical trial data.
Which is a problem.
Yeah.
I mean, there have been other similar cases where drugs that have been used for a particular condition forever, in the absence of trial data, what many would argue was a very misconceived law was passed that allowed companies to, the thought was, well, if a company is willing to do a trial, then we'll give them patent protection on the drug, which previously had been in the public, kind of in the generic public domain. That happened with colchicine for the treatment of gout, and many of us in the clinical community feel that that's just a complete disaster. I mean, we knew colchicine worked. Just because some company does a trial that showed that it works, that doesn't warrant or justify, giving that company the right to, judge or to charge, many dollars for a dose of colchicine, which previously was very cheap. So you're right. That's another huge issue. I mean, I'm not sure what to conclude from that. I mean, there are a lot of things for which there's never been a trial. I mean, there's never been a trial of aspirin for the treatment of headache. There's never been a trial of antibiotics for the treatment of pneumonia. And there ought not to be. I mean, there is a point where we can say we know that something works. Trial is not always necessary. But sometimes a trial is necessary. Hormone replacement therapy for postmenopausal women, we all knew it worked until a trial was done that showed that it didn't work. So this is not an easy conundrum.
I think there's a relatable example for the clinical trials that are stopped for futility, that when new things are tried and they're so effective that they immediately stop the trial because it's unethical not to give the sick kids, especially cancer kids, the drug that's available.
Right.
So the trial was not completed, so it's not a fully powered completed trial, but they stopped it early because it becomes unethical.
So do we really know for sure that the treatment works, even though it looks like it works? So you're right. I mean, it's the same issue. Well, I wanted just to say a word about research misconduct. I mean, it seems to be an increasing problem. We only have indirect measures of it, like retractions of articles, but there have been a lot more retractions of articles recently compared to before. Now, is that merely because we're picking it up more, or is it because the prevalence has actually increased? I mean, who really knows? But there's a widespread perception that the kinds of pressure that people like you guys are going to be subjected to might tend to move you to, consider doing bad things. How can we prevent that? Can the IRB play any role there? Yay or nay?
I think it depends on how the IRB is structured, because I think that's what came from the Gelsinger case, that the IRBs weren't independent of institutions, and there was pressures felt by the IRB to allow projects to go through. So
if IRBs are more independent, maybe they can. Well, we'll talk more about the Gelsinger case. I'm thinking more here about more egregious kinds of misconduct, data fabrication, fraud, plagiarism. Yeah.
Well, you mentioned the increase in retractions. There's also the pressure in getting funded and publishing more, and I think that also drives people. So
Absolutely.
If you have the IRB's oversight,
Absolutely.
The environment is going to.
So the environment is changing. There's the increasing application of metrics to the assessment of researchers. How many papers have you published? How many times have they been cited? What is your H index? And, are you a good person or not? Well, let's look at your index. That's an increasing tendency. And somebody who recently looked at this, and it's, he didn't really, it's hard to, what was the systematic way to look at it? What he did was look at actual cases that had been adjudicated by the Office of Research Integrity. And there's a record of all these cases. And he just sort of went through a bunch of them, 1992 to 2003. What did he see? Mostly fabrication, falsification of data, some plagiarism. What seemed to sort of be the reasons why people did what they did. And he kind of divided it up according to who was doing the bad things. Support staff who really weren't part of the research culture were doing things for monetary incentives. Maybe they had incentives for productivity and they cut corners. They invented interviews that didn't happen just because they had to get so many interviews done and it was hard. For postdocs and grad students, it was especially pressure to publish. And for faculty, it was pressure to publish, which seems to be more now than it has been in the past. Metrics probably made it worse. And Kornfeld actually sort of did some perhaps amateur sociology, but he kind of analyzed what kinds of people were doing these things. Some of them were desperate. They really they would lose their job or they wouldn't be able to go to the next step if they didn't get publication X. So if they just felt like they had to do it. The perfectionist, the ethically challenged, who just succumbs to temptation. I know it's wrong, but I'm doing it because I need for this to happen, this next step in my career. Particularly among more senior faculty, the grandiose. Well, I'm so important that I can basically do whatever I want, and what I choose to do is going to be okay because I'm the one making the choice to do it. That syndrome was among these reports. Sociopaths who had no ethics at all. So the question is, what can we do about that? Is this a research oversight problem? Kornfeld would argue probably no. Can we do it simply by, having you take classes like this one? Can we make you into good people by having you think about research oversight? Many of us would argue probably no. Probably that's not going to work. So there's no evidence, there's never been any evidence that education of any kind changes people's behavior when it comes to ethics. If we want to look at sort of where we might sort of attack this, most of us are going to make the argument that it's going to be in the culture of your work environment, and particularly the culture of the people who are supervising you. Are they really people who want to do the right thing and are not going to allow other incentives to affect the need to do the right thing? If they are corner cutters, you will learn to be corner cutters from them. I would tend to conclude this is not a research oversight problem. The IRB cannot fix this This can only be fixed by fixing the place where you live and work, and in particular fixing the people who are in charge of those places, because they determine the tone. They set the tone. They set how things are done and what the feeling is about cutting corners or not cutting corners.
It's interesting because my sense is that the people who run the responsible cognitive research kind of training expect the culture to bubble up from below, because there's some requirement for lab leaders to engage in some kind of continuing discussion of responsible cognitive research with their research groups, but the real training of people happens when a new postdoc or a new graduate student or a new undergraduate enters a research team. They get trained in a sort of generic way, not specific to the research that's being done, and the assumption is that they will get the right kind of input from above. But the mechanism to assure that people who are getting, who are directing lab groups, whether they have the right kind of information and the right kind of encouragement, it's not based in any kind of real structure to make it happen. One of the things I do outside of this group is I run a series of discussions around the best practices in being a mentor. And one of the things we're about to add into that is a larger component of how you foster an ethical environment in your mentoring team that you work with. And but you know, the participation in that kind of discussion is totally voluntary, and the people who want to talk about it already are pretty good mentors and already think about all the issues, and the people who don't think about it don't show up. So it's a challenge.
So, I mean, I can't really, draw any definitive conclusions about any of this. I mean, I sort of, over the years, have come to some tentative conclusions that, look something like this. The IRB system is useful. It can't do everything. It's not going to solve the problem of research misconduct. It can be a help when it comes to research design issues, consent issues, things of that sort. We ought not to expect it to do things that it's simply the wrong kind of tool to address. Well, having then had this general discussion, let's talk about a particular case. So the Gelsinger case, you looked at some background on this. This was one of the early gene therapy studies that is introducing genetic material in such a way to human beings that it has a therapeutic or diagnostic effect related to the activity of the genetic material in the human body. In the 1990s, we're sort of in the very sort of high excitement. Things are happening. It's a sexy area. It's where it's at from the standpoint of fashion and research, from the standpoint of, what people want to get into, what people want to do. I mean, this is sort of it. First therapeutic gene transfer is done in 1990. As of 10 years later, 90% of the patients that have participated in gene therapy trials, they've all been phase 1 trials. So at a very basic level, looking at safety. The particular trial that Jesse Gelsinger was involved in was for a relatively rare disease, ornithine transcarbamylase deficiency, a genetic defect interfering with ammonia metabolism. And if you have the more severe form of this, you die as an infant. If you have the mosaic, less severe form of it, you have problems, but if you follow a strict diet, you can lead a relatively normal life. And that was Jesse's case. I mean, he was 17 years old. He had to follow a diet, but if he followed the diet, he did pretty well. He'd had a couple of occasions where he had gone off the wagon and not followed his diet and ended up in an ICU and had been successfully brought back. But if he did the right thing with his diet, he was fine. So this study was an attempt to use an adenovirus vector to bring the gene that produced the missing enzymes to metabolize ornithine to the liver so that metabolism could happen rather than not happen, and thereby fix the problem. And it's basically a stair-step dose-response study of an ounce of this fluid over 2 hours to the hepatic vein by a femoral catheter. 3 to 4 subjects get a given dose. If all goes well, the next group of 3 or 4 subjects gets a higher dose, and so on, up through 6 levels of dosage. There is this the Recombinant DNA Advisory Committee. I think I don't want really to talk about this very much. I mean, in the early days of gene therapy, the researchers who were doing this knew it was sort of a big deal. They knew it was going to be controversial. They wanted public approval. So at the level of the National Academy of Sciences, a committee was formed that would scrutinize gene therapy protocols and sort of pronounce, this is okay. It's okay to do this way. And this had nothing to do with the regular NIH process of study approval. It had nothing to do with the regular ethics oversight process. It was a completely separate thing because gene therapy was so special. But this committee had approved the study with infusion into the bloodstream, and the FDA sort of changed that around before the study began and allowed infusion into the liver. And there were sort of plausible reasons why either one might have been superior. And the Research Advisory Committee was not informed of the change. I mean, this is one of the irregularities that maybe things that should have been done differently that came to light after the study was over. So one of the areas of controversy after the study was over was the informed consent document. I mean, what were the subjects of this study actually told about their risks? They were told that this thing could cause liver inflammation that could conceivably be life-threatening, that it could generate an immune response that could damage the liver, and that it might preclude them from receiving a treatment form of this agent if a treatment form was developed later on. And, so what's the actual wording? What was Jesse told? We believe the virus is safe. It's possible that it could cause an inflammation of the liver or hepatitis. It's even possible that this could lead to liver toxicity or failure and be life-threatening, and there's a very small risk of death. Now, interestingly, there have been some prior animal studies. And high doses of this vector had led to the death of primates. And the IRB approved language on the bottom there. In mice and monkeys, high doses of the virus have been associated with evidence of liver inflammation, hepatitis, hepatic necrosis, and death. Boom. However, that language got modified. And what they actually decided to put in, what did they actually put in the consent document? Slightly different language. The animals had not shown toxic effects to the liver or other body organs at the dosage of virus that is needed to transport the gene in this study. We tested the safety of this virus, and we've not found toxicity at the doses being used in this study. So what they had done is they had modified the vector. The first generation vector, they had developed a second generation and a third generation, and each successive generation was less toxic than the previous one. And so what they were using in the study was a third generation vector, and the vector that they'd used that caused the deaths of the monkeys was a first generation vector. and they were also using it at lower doses. So their thinking was, you know, that data about the death of the monkeys, that's not really relevant because it's a different agent that we're using. You know, we're using this third generation agent that's much less toxic, and we're using it at lower doses, so we can talk about that. We don't really have to emphasize the fact that a progenitor vector, you know, caused these major problems in these monkeys in the early stages of our research. We don't have to tell the subjects of this phase 1 study that. The other point to make here is that, you know, so this was a change in the protocol. And the way this protocol was designed, it was designed so that it would change as time passed with each successive group of subjects. There was a waiting period afterwards so that all the data could be analyzed, so that communications could be made to the FDA, and so that for the next set of subjects, if anything happened that, you know, led to the need for a modification to make the next go-round safer, it would be done. So that was intentionally built in, that the protocol would change as it went. And what emerged after the study was over, that in the course of that process, the investigating team was making some changes without communicating them properly back to the various oversight bodies. I mean, they were doing things that they thought were okay, and yes, it was all supposed to go back to the IRB and back to the NIH and back to everybody. A lot of it did get back to those bodies, but not quite everything. This was one of the things that didn't get back. So aspects of the protocol that later became an issue. The study was to be stopped at any point that grade 3 toxicities developed. Findings emerging during the study of relevance to future participants were to be disclosed to those participants. Initially, participants at the highest dose level were going to get the maximum was going to be 100-fold dilution of the vector compared to the doses received by animals. And subjects were to have ammonia levels less than 70 micromoles. Then another aspect of the document, I mean, this is what the sort of financial conflict of interest part, little piece of it, this is what was in the consent document. Be aware that the University of Pennsylvania, Dr. James M. Wilson, who's involved with the study, has a financial interest in a successful outcome of the study. Fairly general language. But just to talk about that for a minute, I mean, it turns out that the reality was very, very complicated. And I don't want to belabor this, you might not even be able to read it, but basically, Wilson had a major equity stake in Genovo, which was a company which would develop technology that came out of this study if it was successful. That company basically was funding his entire center at Penn. So the entire budget of his center came from the company. And Penn, in return, was going to grant a license so that any technology that came out of the company, Genovo would be able to commercially develop. And Wilson would clearly benefit greatly from that since he owned a third of the company. And, you know, so what was the magnitude of his sort of financial interest here? At the time, people in Penn's Conflict of Interest Committee thought it was on the order of $30 to $40 million. So it was huge. So, you know, and Penn, unlike many institutions at the time, actually saw this as a serious issue, put the issue to themselves, how can we deal with this? Is it okay for this to be? You know, for somebody who's involved in a study like this, to have such a huge financial stake in the outcome, is that reasonable? Well, let's take it to the Conflict of Interest Committee and see what they say. Well, and the Conflict of Interest Committee looked at it very carefully, and what they decided was that given Wilson's expertise, given Wilson's key role in the development of thinking about how to do gene therapy, he was an essential piece for this to go forward. Yes, care needed to be exercised given this financial sort of benefit that he stood to get. So his stock will make his stock non-voting. He won't be making decisions at the level of the company, and he will not be involved in design of the trial or decision making. But he'll still be around. He'll still be sort of, in close communication with the PI and the other investigator. I mean, his presence will not be removed, but in theory, his active participation will be removed. And they decided that that was an adequate management of the conflict of interest here. Now, what is the conflict of interest? You all have a sense of what it is?
Monetary, yeah, financial gain, yeah.
He has a bunch of equity in the company, so if the trial pans out well,
He's so interested in the company, will he somehow cut corners to make the trial succeed? Will he do things improperly to make the trial succeed because he has such a huge motive to do so? So their thought was, this is a conflict of interest that, this is worth putting up with because he's such an important person for the success of this entire thing. We need this to work. Society will be much better off if we have successful gene therapy. So, we need to permit things like this to happen for that reason. Yes, it's not ideal, but we need to do it. And so a lot of the argument became, A, should this have been really permitted? I mean, did the conflict of interest committee make the right decision? And B, if it was permitted, was this enough to say? I mean, maybe, should the participants have had a little more information about the magnitude of what was going on between Wilson and Genovo? So the trial begins in 1997. It actually extends over a period of 2.5 years. I mean, because of this design, there's a pause after each group gets its treatment. 5 cohorts over that 2.5 year period receive the vector. They do okay. There is some toxicity, and it turns out that some of these are grade 3 toxicities, liver inflammation, fever, transient lab abnormalities. Nothing super serious, but according to the protocol initially actually would have led to the study being stopped at the appearance of some of these toxicities. The study was not stopped. So second subject of the 6th cohort, the first gets the dose that Jesse gets, has minor toxicity but doesn't have any major problem. So Jesse's the second subject of that cohort. He gets the vector. It's not an 100-fold dilution. It's only a 17-fold dilution, so the protocol has changed again. And he gets very, very sick pretty soon after he receives the vector, develops widespread inflammation, disseminated intravascular coagulation, multi-organ failure, acute respiratory distress syndrome. He's in an ICU for several days, and he dies. What happened? And it's still not totally clear what exactly happened. I mean, James Wilson eventually wrote about this, his own thought process trying to figure out what happened to Jesse. His best guess is that somehow the vector triggered an immune response in Jesse, and that immune response was what killed him. How exactly it happened, not completely clear. Why it happened. Why did it happen just to him and not to anybody else? Question mark. So needless to say, after Jesse's death, everybody sort of scrutinized what had happened with a microscope, including the NIH, including the U.S. government, Jesse's family and their lawyers, the institutions in which this took place, and the press. I mean, everybody looked at this very hard. Criticisms of the study emerged. Jesse at the time that he was infused, his ammonia level was higher than the protocol specified was allowable. He was a little bit over 70. The issue of the animal data, the thought was that that should have been made clear to the participants, and it wasn't. There was the issue of notification of the oversight bodies when these various predetermined benchmarks were reached. And they were reached, and the oversight bodies were not notified. A lot was not communicated to the FDA involving changes in the protocol. There had actually been some changes that were agreed to by the investigators that might have excluded Jesse, but those changes were not enforced. The design of the study became an issue. And the question is, why test this in somebody like Jesse Gelsinger? Why not test it in an infant with the more severe form of OTC deficiency who has a much worse prognosis and had less to lose? Would that not have been more ethical?
Why didn't they do it? That's interesting.
It's very interesting. And they actually consulted a bioethicist, a guy named Arthur Kaplan. And one of the issues of controversy also became the fact that Kaplan was actually, his professorship was paid for by the center for which Wilson worked. So in a way, I mean, he also had a financial stake in the whole thing. But he sort of scratched his chin and said, you know, the key issue here is consent. And if you're an infant, a sick infant in particular, you know, there's no possibility of consent. Whereas somebody like Jesse Gelsinger, an adult, can give consent. That's really important. That's why we need to do this in an adult and not in an infant.
That makes no sense. I mean, the parents give consent, right? If it's a minor.
Yeah. But it's the parents, it's not
Yeah.
the infants, it's...
Now, I think one of the articles said that the parents of the infants would be so distraught knowing that their child was going to die.
Right, so...
Parents would be so distraught knowing the child was going to die that they wouldn't be able to give informed consent. It would be like,
Or their
do
consent
whatever you
would be-
can to possibly save.
Their consent would be
child.
tainted by
Yeah.
the situation that they're in.
We do that all the time in cancer care. Yeah, it's like that's just nonsensical.
Yeah.
Because that's where the risk and benefit, right? The risk and benefit of participation. So if you don't participate, we know the outcome is death. If you do participate, we don't know the outcome can still be death.
So the minimization of risks and the adequacy or the purity of consent are the two sorts of things that we're weighing in the balance here. And Art Kaplan said the purity of consent is the important thing.
Now the other side is you're looking for the toxicity of the drug, and if you are trying that on a sick baby, and it may be a little bit difficult to determine if the baby getting worse is because of the medicine.
Very good point.
Or the natural force of the disease.
Very good point. I mean, to what, you know, might that muddy the waters, the fact that the baby is sick and is deteriorating anyway, and make it more difficult to distinguish toxicity from natural history. I don't know if that was a determining factor you're thinking, but it's certainly a plausible one. So I agree with you. I mean, I think, you know, there's an argument there, and it's not clear that they necessarily made the right decision. They did think about it. They did everything right. They consulted a bioethicist. They got an answer from the one of the gods of bioethics, and they proceeded accordingly. So that was a question, and then the whole, financial conflict of interest was a question. And in the immediate aftermath of the study, the financial conflict of interest issue was what dominated discussion. This is an example of research gone wrong, because of financial conflict of interest, and, evil drug companies are the source of so much badness in our current society, and isn't this an example of that? That was probably the predominant portrayal of the whole thing in the press shortly after all this happened. So there were some lawsuits. Penn basically settled. Basically, one lawsuit from Jesse's family, another lawsuit by the government under the False Claims Act, legislation which the government has used to sue many drug companies for various kinds of malfeasance. And the accusation here is that the misrepresentation effectively to Jesse in regard to omissions in the consent form, amounted to false claims being made. Things were one way when they really were another way. And that needed somebody to pay for that. So Penn settles both these cases. And that's as much as I want to tell you about the case. How do we look at this case in the light of research oversight? How do we look at this case in the light of what an IRB might have done? Does this case illustrate the failure of the research oversight process? You all have any thoughts?
I have a question first. I just don't know this. Like, whose responsibility is it to ensure that researchers report addendum to protocol or updates on toxicity? Is that given to the researcher as a, okay. Well, I mean, in that sense, then there's going to be some limitation potentially to people not wanting to report things that go wrong. So, I mean, that's a whole other can of worms ethically if people will even report that.
So if you don't report something, your study is doing what it's doing, and something happens. I mean, you're the person who makes a decision that it ought to be reported, and then you're the person, you the researcher, make the decision to actually report it. And nobody's going to miss it if you don't do it. There's nobody in your, there's nobody in your process from an oversight body. They're completely dependent upon you for all this to happen.
And I think that's a failure of oversight of research.
So supposing you were a member of the Jim Wilson's research team and you saw that there were reportable things that should have been reported and you had concerns that they weren't being reported, what do people think the obligation of a team member is in that, and how, if you were here at UAB, what would you do about it?
Audit.
How? So you have to report it, but how?
Well, so there's avenues that if you are questioning the ethics of a project you're involved in, that you can report, and you can report anonymously or you can go on the record. But I think the onus is to report. But, I think this goes to, if you're relying on people to report, there's always going to be error. So it's how much error we're willing to tolerate. So one could argue that all this oversight should be automated, that it all goes into a database and there's some sort of computer algorithm that's looking at the data that's going in and making sure that it matches your protocol and gets flagged.
That's not a bad idea.
But because if you're relying on people to report, I think this will always, human behavior, unfortunately, has set a precedent.
So I partly brought this up to be sure that everybody knows how to report. So you mentioned that there are ways to report anonymously. Do you know the specifics?
No, but I know how to find it. So you go online and you can find a number that you can call.
Right, so there is a UAB ethics hotline. And if you just Google UAB ethics hotline, you'll find it, and you have the potential to report either anonymously or you can reveal who you are. If you reveal who you are, then anybody can know who you are. So, and there are some limitations to how far it can go if you don't list who you are, but at least you can get the process started.
So David, are you saying that if someone here, for whatever reason, smells something bad in their lab, they should immediately call the UAB ethics hotline?
So that's a really good question. So it depends what the history is. I think it can be very complicated whether you challenge the person you work for to report it. That would seem like the reasonable thing to do would be to have some discussion.
Surely wouldn't you do that first?
You would think you would do that first, but I guess it depends what you know about. If you know there's already been encouragement for a person to report, to self-report, and it hasn't happened, then I think you have a much tougher decision-making process. I don't know. What part of the process is to have reasonable care not to damage the reputation of the people you work with in an egregious way, too. So you need to play fair in the process.
So one thing that I was thinking, reading this case, wasn't Penn State kind of like somehow invested in a sense in this study? And then last week our speaker discussed, when you have an ethical breach or if there's a concern, then the committee, comes and investigates. And it sounded like it was a really big deal for something like that to happen, not just like we're going to look into it. I mean, they say they come and they collect your records, they, review all this, and then of course you think about possible jobs lost. So if you're a lab technician who is, this is your job, you're worried that, I might not have a job if I'm the one reporting this, or my colleagues, maybe they, have some situation where they need this job to survive. I mean, there's a lot of, I think it's not
if you're going to be a
cut and dry.
whistleblower.
Yeah, I think there's a lot of things to consider in a situation like this because, it's just very, it can be very detrimental, and maybe someone who's in a lower position doesn't necessarily feel that they know all the, ins and outs of what's truly going on to report. So I don't know. I think this is tough.
It's very tough. So I would actually encourage you. So the Office of Research Integrity at the I guess it's the Department of Health and Human Services, has a series of interactive videos that go through a case like this. And, it does it from the perspective of the person in charge of the protocol, the person who's an associate, a graduate student, all these different levels, and what happens if some of it's pretty corny, but it's what happens if you don't say anything. What happens if you do say something? And it brings up a lot of issues that are worth having thought about in advance, because I can tell you when a big issue like this comes up, if you haven't thought about it in advance, it's not always easy to have the clearest thinking process active.
So based on those videos, what I have learned is that it's usually a good idea to talk to your PI, and they might give you justifications for what they're doing. Like my colleague just said, that there was a proper, authentic, or reliable reason why not to use infants. So that's something that inexperienced or junior researchers might not think of, but that's something to think about. So in some cases, PI might have a justification of not including something in a protocol or changing a protocol in some way, and if you're satisfied, then good enough. But at least the first step, in my understanding, would be to discuss what are the possible reasons for those changes, and if you're satisfied, good enough. If not, then you can blow the whistle and go out there and report it.
So we're getting pretty short on time. Let me just try and wrap up a little bit. I think the protocol and the protocol violations were a huge issue, And looking at it from the investigator point of view, I mean, I think you could say, well, how serious really was this? I mean, the 70 micromole limit on ammonia, well, patients with ornithine transcarbamylase deficiency, their ammonia goes up and down. And the protocol just wasn't written correctly. I mean, it should have allowed for clinical variation in the level of ammonia. And if the patient's doing okay, which Jesse was, I mean, that should not have been a bar to him participating in the study. A plausible point that the investigators would make about that. And then, they would say, well, grade 3 toxicities. Well, these grade 3 toxicities were really not serious toxicities. And the problem was with the protocol. It should not have been written that restrictively. I think those are valid points. But on the other hand, I think also the fact, they acknowledge that they did not do what they said they were going to do. And they did not communicate the changes when they didn't exactly follow the protocol, even if, a case could be made for what they did. And in retrospect, I mean, one of the things that Jim Wilson says is, if you have a protocol, you need to, it needs to be your Bible and you need to follow it and you need to, I mean, that just needs to be something that you very, very carefully adhere to. And you cannot afford to be careless about the protocol. And they acknowledged that they were careless. Could all that have been prevented by an IRB? I would tend to argue no. There's no way that could have been prevented. An IRB is not going to be looking over their shoulder that closely, and it's not practical to expect that an IRB should do that. This is not an issue that an IRB could fix. Was it the case that the financial stuff here was sort of, everybody's, the dials in their heads were all pointed, too many of them were pointed in the same direction. They were so eager that maybe that made a difference. They would say, there's no way I can separate that out from all the reasons I had to want this to succeed. I was after glory, I was after fame, I was after, publications and recognition from my peers, I was after academic success. Wilson would say all of that was way more important in his actual decision-making than the money. And I think most of us would probably agree that all those motives are mixed together and we can't really sort them out. But that nevertheless, Wilson should not have been, the arrangement was he was going to have no on-the-ground decision-making, and yet he was in the room when many decisions were made, and that probably should not have been the case. He should have been more separate from the study than he was, simply from a prudential standpoint. I think most people who have thought about this would say that. Many of us would say that the real issue here, which the IRB could have addressed, was the use of infants rather than adults, and that was really a key issue, and that many of us would say Kaplan made the wrong decision. Any of us with a clinical background would tend to say that. We would want to argue that the medical welfare of the patient is much more important than giving consent or not. Giving consent is important, but it's not as important as whether somebody lives or dies. That's a clinician point of view. It's less of a bioethics point of view. But the IRB really could have had an effect there, and they didn't. So a mixed bag, and hopefully a stimulus to your further thought about research oversight and how it can be made different. There have been some changes in the last year. We're not going to have time to go through them. They're relatively minor. The process basically is the same as it has been after the new rule. Thank you.
So Jean has put a sign-up sheet for the IRB visits on the table. On the way out, try to sign up if you can, and if you need to.
One per session.
There's 2 people who go over time, so there's room for 2 names on each day. So the process will be that you'll leave here at 9 o'clock to go to the AA building right across the street. And just the same half of the session. so much.
Yeah, I want to talk more about finding something.
Sounds great.